Okay. Hello, everyone. Welcome. My name is Laura Turner, and I am the Executive Director for the Health Professional Student Association, which publishes the Student Doctor Network. And I'm very honored and excited to be here today, to join you today with Dr. Michael McDowell, who is a pediatric neurosurgeon. Dr. McDowell is a graduate of the Columbia University College of Physicians and Surgeons and the UPMC neurosurgery program. He undertook fellowships in endoscopic skull-base surgery and pediatric neurosurgery. Currently, Dr. McDowell is faculty at UPMC Children's Hospital of Pittsburgh, specializing in skull base and craniocervical junction disorders. He has research interests in non-invasive intracranial pressure monitoring. So with that, before we dive in too much, I'm going to jump in. Let's see if I can share this slide here. I'm just going to do a quick overview of Student Doctor Network if you're not familiar with us. The Student Doctor Network, most people know us from the forums, but we have a lot of other tools available, including our medical school application cost calculator, which can help you figure out what your costs are to apply to medical school. The Student Doctor Network community, forums community, which a lot of people are familiar with. And I think that's all there is in this presentation. So with that, I'm going to go ahead and turn it over to Dr. McDowell and allow him to introduce himself. So let me get him. He can be there. There we go.
Hi, everyone. Laura kind of did a great job with the general overview. The only other thing that I think I would add is I'm also a longtime moderator at Student Doctor Network. You may be able to figure out who I am based on my handle, and it is a pleasure to continue to serve the community.
And we very much appreciate that you do. So thank you for doing that. So, okay, we're going to go ahead and start with our questions now. So first question, when did you first decide to become a physician and why?
So I've had a long history of wanting to be a physician. When I was a very young child, I wanted to be a veterinarian, but it became pretty clear early on that I was allergic to every animal besides people. So that kind of simplified that interest. I certainly had interest in it as early as high school, but I guess I would say that while that interest existed, I kind of did the opposite of a lot of people, and rather running towards medicine, I ran away from it as much as I could, really to try to justify my interest in it. So, I explored a lot of different interests in college, hard sciences like chemistry and biochemistry, entomology, which is the study of insects, and dance, which is something I got a degree in. So I really had in the back of my mind this interest in medicine, but spent a lot of time kind of validating it by excluding other fields of study.
Great. So entomology, that's a bit different. I just wanted to let everybody know, if you are watching this live on any of the streaming platforms on Facebook or on YouTube, you can put a comment in if you have a question for Dr. McDowell, and we'll be able to pull that up on screen and you can ask it to him directly. So we're going to jump now to a question about how you chose the medical school that you attended.
So this is, a really critical question to consider. I'm a big proponent of attending a medical school based on fit. Fit is a multifaceted concept that can include a large array of topics, including financial security. Going to a school that ensures you not being drowning in debt and able to also kind of take care of any responsibilities you may have for a family, for example, is something that should be considered into the fit category. So I was very interested in a school that was pass-fail for the preclinical years, and a school that had a condensed preclinical curriculum and an extended clinical curriculum. And I was interested in a school that had a very strong student culture, and in some ways an esoteric culture. And so that was really why I was attracted strongly to Columbia as kind of my top choice. I had the privilege of interviewing and being accepted at a number of other programs, and they were all phenomenal programs ultimately, but really that strong student culture, as someone who had kind of spent a lot of time in non-medical interests, that was a huge draw for me. And I also wanted the experience of living in New York City. So Columbia was far and above my first choice. I did write an intent letter there. And fortunately, I was lucky enough to be accepted.
Great. And I imagine New York City must have been quite an experience. Were you from a city growing up, or had you never lived in a city before?
I was a military brat, so I lived at a large number of places. When I was very young, I lived in San Antonio, but for most of my childhood, I've never really lived in an urban environment. Even San Antonio, we lived so far into the suburbs that I wouldn't really call it an urban environment for my childhood. So where I came from, before college was, a town of 5,000 people.
Yeah, so that must have been quite a culture shock.
It was a shock.
I just want to remind everybody, if you do have questions, feel free to put them into the comments on YouTube or Facebook, wherever you're watching, and we'll be able to pull them over so you can ask Dr. McDowell any questions you might have. We'll go ahead and switch to the next question, which is, why did you decide to pursue your specialty? In particular, not just your surgical specialty, but then, diving in specifically into pediatric neurosurgery.
So a lot of people will tell you that you should only go into neurosurgery if it's the only thing that really excites you and interests you. I don't really agree with that. I enjoyed a large number of specialties, both surgical and medical. A lot of things that I could have seen myself being content in. So for better or worse, the reason I was most attracted to neurosurgery was the people within it. I was very exposed to them very early in medical school. Columbia does a very nice job of getting all of the subspecialties involved in your preclinical education, and I was very much impressed by the general cultural attitudes within neurosurgery. It's a field that really values a high level of personal investment and commitment and integrity related to patient care. It also has a very strong kind of perfectionism and work drive kind of culture, and I was attracted to those features of it, and that was a major reason why I ultimately applied into the field. Similar to college, I did spend much of my time in medical school trying to prove myself wrong that wasn't really what I wanted to do. So I spent a lot of time in other fields, including pediatric neurology, oncology, radiology, ER, pediatric ER. And I encourage people not to shut themselves off just because they are convinced of what they want to be interested in. I think you really owe it to yourself to prove it through exclusion. My interest in pediatrics definitely exceeds the length of time that I had an interest in neurosurgery. I've always enjoyed working with children. I did a lot of kind of child outreach in college related to education. And I also used to be a magic enthusiast and have a fair number of magic tricks still from my earlier days as an amateur magician. So the things about pediatric neurosurgery that I like the most, there are a lot of not necessarily hopeless cases in pediatric neurosurgery, but there are a lot of cases that can cause a certain amount of emotional turmoil in people taking care of them, in things that are really either tragic or just situations that can really stir up strong emotions. But the flip side of that is, nowhere nowhere out of pediatrics can you really feel like you're making a difference in someone's life than in a child. When you take out a subdural from a trauma in an older person, that's a good thing, and that saves their lives, and they go on and hopefully have a good remainder of their life. But when you do that in a 2-year-old or a young child in general, the infinity of possibilities that you're giving them in their future to live a normal life, it's incomparable, and it's just a tremendous feeling, of achievement.
Yeah, that's it's I can tell how passionate you are about kids and like the idea of helping them, based on what you said.
Well, when you think of it, is children really are not accountable for the things that happen to them, right? No, a child didn't smoke and get lung cancer or brain cancer, so the things that happen to children really are beyond their control. And that innocence of accountability really, I think, justifies what we call heroic measures when it comes to trying to treat children.
Now, given all of your interests, and that you said that there were a lot of different things that sounded interesting to you, and that you enjoyed doing, if you had to do it all over again, would you still choose pediatric neurosurgery? And if so, why or why not?
Yeah, I would not change any major part of the path that I've taken. I think the reason for that really goes back to what I was saying earlier, which is you need to validate your interests by exploring other fields. So I don't look at other fields with envy, and I see them going home earlier than me, or doing cool procedures, because I did look at them before I made this decision. It was as to the greatest extent that a layman can achieve an informed decision. You can't go through every one of these residencies and really dive to the deepest possible level before you make a permanent decision, but you can spend a few weeks, on any given specialty or subspecialty, and really ask yourself, is this what you really want to do with your life? And I think I did that part by personal exploration, and partially because of my curriculum, which, as I said before, did expose me to a lot of specialties, and also it had essentially a minimum of 1 week of clinical rotations in essentially every specialty. And so I think that was a tremendously useful experience, not only because it really, I think, let me convince myself of my choices, but also I think that every specialty has something to teach you, regardless of what you want to go into. And I think being exposed to as many of these specialties as you can provides beneficial skills and knowledge that you'll use for the rest of your career. The time I spent on neurology, for example, has had a significant impact in my ability to place Foley's in the OR and manage urinary retention postoperatively. in terms of, other specialties. ENT, very useful in terms of having basic otoscopic skills. Many, especially in pediatrics, many patients present with infections that arise in their ears. So whatever you end up in, going and spending some time with these fields, you can learn things that will benefit you and justify the time expenditure. Neurosurgery, you don't have to be interested in neurosurgery. The reality is a lot of specialties need to be able to do lumbar punctures, and nobody does as many lumbar punctures outside of maybe interventional radiology than neurosurgery. So learning how to do a neurosurgical lumbar puncture is a skill that can benefit you, even if you don't want to be a neurosurgeon.
Oh, thanks for breaking that down. I want to remind everybody, if you do have questions, please feel free to put them in the comments if you're watching on YouTube or on Facebook, and we will answer those questions live here with Dr. McDowell. So, there's this impression of like, what does a brain surgeon do? I don't think people really have a good understanding of neurosurgery. So can you talk a little bit about what a typical day looks like for you?
Yeah. And, I can touch on briefly just kind of the variances that can occur. Neurosurgery is a very broad field. Obviously we have subspecialties like pediatrics, but we do everything from vascular and endovascular, functional and epilepsy, which is things like deep brain stimulation for Parkinson's, tumor, spine, which we share with the orthopedic surgery world. But we also do radiation oncology and what we call radiosurgery. So we do things in various functional disorders like trigeminal neuralgia. So you really have an opportunity to subspecialize a lot in your particular interest. The reality is most non-academic neurosurgeons primarily do spine. As a pediatric neurosurgeon, the vast majority of pediatric neurosurgeons are affiliated with academic hospitals, partially because pediatric neurosurgery being such a niche really doesn't exist outside of a children's hospital, and concomitantly, most children's hospitals are academic in nature because there's very few of them. So there aren't really there are some, but there aren't that many purely private practice children's hospitals. So if you're going into pediatric neurosurgery full-time, you're really looking at an academic appointment. If you're looking to just do partially pediatric neurosurgery, there are many private practice groups that do some pediatric neurosurgery that you could potentially fill that role, but it wouldn't be a full-time job. So this year I'm finishing up my fellowship in pediatric neurosurgery, which is a one-year fellowship required in order to be a pediatric neurosurgeon. It cannot be done enfolded, meaning it cannot be done in or during neurosurgery residency. And the reason for that is it is in fact a separate specialty, with the prerequisite being doing a residency in neurosurgery. So there's really no way to kind of get out of that continuum of education, which is a 7-year neurosurgical residency and a 1-year pediatric neurosurgery fellowship. The nice thing about pediatric neurosurgery fellowships is many, if not most of them, do provide you with faculty privileges, meaning that you are able to practice as an independent surgeon, and it is more of what we call a finishing school, where other surgeons will provide input and suggestions while you and your residents kind of perform the majority of the cases by yourself. So at my institution, I wake up around 5:30, have some coffee, review charts that may have occurred overnight. And then I arrive around 6:30 at the hospital. The residents at that time have already kind of prepared a list, chart reviewed on all of the patients. The senior most resident, which we call the chief resident, will then present to me very briefly the the events of the patients as well as any new patients overnight, provide me with the plans that they recommend. I will, I've already looked at most of the films at that point, but I'll review anything that I may have missed, and then provide any editing of those plans based on my own personal preferences and experience. We'll then usually around 6:45 go and see all of the patients on the service, which is usually about a half hour. I spend most of my time talking to families and distracting them while the residents actually do the kind of nitty-gritty examinations, which can be sometimes distressing for families, to watch. So that kind of helps reduce the level of anxiety because they're kind of talking to me about the plan and me asking them any questions they may have or concerns they may have. And after that, usually around 7:15, I go down to the preoperative bay to sign in any patients that we may have, and then operate, throughout the day until we're done. Some days are long, some days are short. Usually, I'll round in the afternoon briefly on primary neurosurgical patients a second time, just to check in. I try to do it very early between cases around noon, just so that there's time to kind of modify any issues that they may be having. And once the surgical day is done, I go home, and residents will call me with any urgent consults or questions that they might have overnight. And I'm kind of on what we call backup call most nights, where they'll call me if there's a concern or an operative problem, and everything else they kind of just manage autonomously.
So you're in the surgical suite every day, basically.
Yeah, at least 5 days a week. It can be all 7. It depends. I do take time off. It's not, it's not. It sounds more brutal than it is. The great thing, for the sake of children at least, is pediatric neurosurgery is rare. So it's not like we're getting 20, 30 new cases a day. It tends to be a fairly sleepy specialty compared to other aspects of neurosurgery. So, I get plenty of sleep, and that's not really been an issue. And I take about 2 weekends off a month. Essentially, I tend to take them just one day at a time because I'm from Pittsburgh. I did my residency there, so I'm not, that's where my family is. So I'm not running around, trying to go visit family in another city or a spouse that's not with me. I'm a full-time member of the Pitt community, and I'm staying here long term.
Sounds good. We've got a couple of questions that have come in, so we'll go ahead and start putting those up. This one is about the residency. It's from Derek Lewis. And what were the most important factors for you in choosing your residency at UPMC?
So I went to Columbia for medical school, which was a phenomenal experience. And my experience with the neurosurgical field through Columbia was great. And I have lifelong mentors through there. But Columbia is what you might call a boutique program. It's obviously in a very competitive city with a lot of neurosurgeons, and it has a very powerful academic name associated with it. And so it tends to be a more academic experience where you spend a lot of time early on getting lots and lots of kind of didactic education, and your operative experience kind of comes after you've done a lot of didactic education. This is the kind of program that tends to destroy the neurosurgical written boards, for example. They really, very frequently, hit the 99th percentile of that, because the core of their early education really does revolve on classical neurosurgical papers and review, and they do a great job in that. I do not consider myself a naturally skilled surgeon. I don't, in general, the more that I've trained and the more that I have been exposed to different surgeons, I've gradually lost faith in that concept at all. People often talk about having good hands. Oh, he's got good hands. They don't have good hands. My experience has been, having been involved with about 30 neurosurgical trainees as well as 30 neurosurgical attendings, is that is an excuse that bad surgeons use to justify their inability to do certain extremely technical aspects of neurosurgery. And it is a mythology that is propagated by those who have in order to exceptionalize themselves. I think 99% of surgical skill is through training, study, and practice. And if I had the pleasure of spending some time with one of the greatest neurosurgeons of kind of the last generation, Robert Spetzler. And even in his 70s, near his retirement, Robert Spetzler, at the end of his operative days, would go up to the anatomy lab and practice surgical technique on cadavers. And that's how he became Robert Spetzler. He wasn't born an extraordinarily gifted aneurysm surgeon. He forced himself to become through rigorous study and practice. And so that was something that was very important to me. Was I wanted to go to a program that was going to immerse me in as much rigorous practice as I could get. And so I focused very heavily on what are called operative powerhouse programs, places like the Barrow Neurological Institute, Mayo Clinic, Indiana, and of course UPMC. What I liked about UPMC is, while it had this strong history of extraordinary operative volume and training, it also had very strong academic ties and infrastructure for people interested in pursuing an academic career, particularly for people who are interested in technology because of their very strong relationship with Carnegie Mellon University, which is kind of tied together with a institution called the Pitt Innovations Institute. And they focus heavily on technological applications and commercialization, led by physicians and scientists. And so I don't know exactly how many papers and book chapters that I published during residency, but it was about or more than 60. And
Wow.
I won a number of grants and major trainee awards during that time. And so, I still had that opportunity to, explore academics and build myself up as an academic, because I knew I was going into pediatric neurosurgery. So I knew I needed to be an academic. But I also, really, was flooded with operative cases. The average trainee logs about 1,400 surgeries during their residency. I focused, in skull-base, which is a fairly lengthy surgery. So we're talking about often just one surgery a day, lasting 10 plus hours. But even with that subspecialization, I logged about 2,500 cases, which is about 2 standard deviations above. My co-residents who focused in spine and endovascular, the endovascular guys logged 4,000 cases because endovascular cases are very quick, but the spine guy logged over 3,000. So that was very important to me. That's why I chose UPMC. There's always a price, right? You don't get to publish dozens of papers and do massive number of cases and go party every night or sleep 20 hours a day. There's a finite limit. There's no perfect program. And so I encourage people when they're looking at programs is first of all, don't be seduced by prestige. If you need prestige, do a fellowship. It's much shorter and much less painful. But look at the pros and cons of a program and ask yourself, are these the pros that are most important to me? And are these the cons that are least important to me? I was single. I wasn't super concerned about, having lots and lots of free time. And to me, the exceptional operative and academic opportunities, were worth the busy workload. And that's, that doesn't mean I was smiling and giddy when I was finishing a 26-hour surgery, right, which I have done several during residency, but I recognize the value of that, and I never regretted the commitment that I made to get that value.
Great. Well, thank you, Derek, for your question. We have another one here from Weird Little Dreams, who asks, did you complete any enfolded fellowships during residency?
Yes, I did a endoscopic and open skull base fellowship. One of the other nice things about the UPMC program is it has the longest kind of amount of elective time allowed by the ACGME, which is 18 months for neurosurgery. And so, or actually, excuse me, 21 months by the ACGME. And so I spent those 21 months doing exclusively endoscopic and open skull base procedures. That's an extraordinarily rare field in pediatrics. So I didn't do that fellowship with the idea that I would exclusively be doing pediatric endoscopic skull base surgery. I'd have to do the whole world's pediatric endoscopic skull base surgery to be a full-time practitioner of that. But I did value the microsurgical techniques that are so important in skull base, and just the technical complexity. It unquestionably, my mentor, through hours of torture and tearing out my sutures and otherwise, giving me gray hair, he made me a much better surgeon. And many of the techniques that I learned in skull base, I have now transitioned into pediatric surgery, and I've been able to really kind of find some unique applications of those, to the point of even patents for new tools specific to the pediatric world, to kind of take those techniques and apply them to my current profession. So that was a great use of my time. It also taught me some other valuable skills. First of all, it taught me the value of cadaver surgical dissection. And, I took thousands of kind of high quality 3D photos of different cadavers that I dissected over the years, doing a number of, classical surgical approaches, and also attempting to innovate with some new ones, one of which is in the process of being published now. And the other thing that it taught, we video everything in skull base, because skull base has a lot of complications, frankly. And it's good to have those videos to be able to review and understand what you could have done better. But the side value of doing all of those videos is that I now have a personal resume, a video resume of my own procedures that I did on camera, which I can then pull up for talks, I can pull up for interviews, whatever it may be. That has been an enormous resource for me, especially as I started looking for jobs and being involved in kind of the forefront of academic neurosurgery.
Thank you, Weird Little Dreams, for that question. If you have additional questions, feel free to put them in the comments for YouTube or Facebook, wherever you're watching, and we can bring them up. We have another question here from Jacob Hansen, who asks, what is your advice for a current first-year medical student who wants to pursue neurosurgery residency without a home program?
Well, Jacob, the hard truth is that's a tough position to be in. It's not an impossible position by any means, but it does require additional initiative on your part. The issue is neurosurgery is a small field that really hasn't grown much. It's been about 3,000 providers for the last 20 years. And that means that the movers and shakers of neurosurgery all know each other very well. And it is a tight community of interpersonal communication and networking. So you really need to find yourself a mentor and a pseudo home institution to really kind of help bolster your chances. So I would look up kind of the closest neurosurgical departments, academic neurosurgical departments, and really reach out to them and reach out to your student advisors to see what you can do within the confines of your curriculum to spend as much time interacting with that kind of home department that you can, because it's frankly, it's hard. Most neurosurgical research is clinical. There is some basic science, but regardless, basic science or clinical, it's very hard to do that when you're not in a hospital system. Right? Even clinical research requires chart review, which requires access. It's very hard to be handed a project that has everything done except for stuff you can do at a computer in the middle of a desert. It's just the reality of the situation. So, considering taking a year off at that program, certainly doing as many elective rotations, research or otherwise that you can at that program, that really is your best opportunity to develop a rapport with people who then will go to bat for you and write you good letters that other people that know them throughout the country will read and value. So that would be my advice is, it does require a little bit of proactive work on your part. It's certainly not an impossible battle, but it is a little bit of an uphill one that does require initiative and effort. But I've seen many students without home programs be very successful in the match. But the onus is on you. No one's going to hold your hand. Neurosurgery is not a hand-holding field, and ultimately, people aren't going to have a lot of sympathy for you if you don't put in the work.
Well, thank you, Jacob, for that question as well. We're going to switch now to one of our ones that we ask everybody, which is, what do you like most about being a physician, and what do you like least?
Well, I will say, specifically in my field, the thing that I love to do most, and that I take the most satisfaction with, is to do spinal cord tumors. Taking out a spinal cord tumor is, as close to, feeling, near to God as I've ever felt in my life. It's truly an extraordinary experience when you do a surgery on an area that's only, at most a half-inch wide, and the patient wake up and they're moving their arms and legs. It's just an extraordinary sense of satisfaction and accomplishment to be able to safely remove one of those, especially in a child, and for them to be able to walk around and eat and drink and use the restroom and have no real consequences for working on something that really, up until a few decades ago was just inconceivable. People, there's still echoes of it nowadays in neurosurgery, But the people have forgotten over the last 50 years that being sent to a neurosurgeon in the 1950s was considered a death sentence. The mortality rates were as high as 50-50, and the morbidity rates were equally high. And so, when people talk about the stereotype of a neurosurgeon being arrogant and aggressive and extraordinarily nitpicky, there's a reason for those things. Those are what I call functionally dysfunctional traits. They are terrible outside of the OR, if you can't turn them off at the end of the day, and don't make us any friends. But the reality is, in the operating room, though, like that meticulousness, that absolute insistence on perfection, it paid off. It slowly chipped away at that extraordinarily high mortality and morbidity rate, and allowed us to turn neurosurgery into a field that people, from all intents and purposes, can expect, fairly regularly to wake up and be normal after. And that's a great achievement. So, that's things like that, like spine surgery, is what I like most. And then more generally, I like the saves. I like the tremendous wins when someone comes in, and if you don't operate on them, they're going to die, and then you save their life and they wake up normal and they go on and have a normal life. As I had said before, doing that for a 3-year-old, you're giving them an infinite number of futures, and that's just an immensely satisfying experience to know that this person would have ceased to exist if you hadn't operated on it. It may or may not be the most complex surgery you do, but in terms of what it provides and what it gives to another human being, there are few things in life that you can say have given someone 80 years of future, and that's one of them. So that's my favorite thing. And the thing that's the least is what I use those cases to brace myself for, which is the extraordinarily tragic losses. I had a child who passed away because of an accident involving their parent, who was directly responsible for ending their life by accident. I mean, I can't think of anything more tragic or painful for a parent to go through than knowing that you, by no intent of your own, resulted in the end of your child's life. Like that, that's a heart wrencher. No matter who you are, watching someone go through that agony is just a truly terrible thing. And so, you have some of the worst moments in medicine in pediatrics and in children, and you have to learn to kind of get through those. And I use the successes to kind of hold myself through those. But sometimes you get a bunch of those cases in a row, and it can get really, really burdensome on you. Just bad situation after bad situation after bad situation. You just really are hoping for a win. One of those wins to back. I've had children who, I saved, and they could have woken up and gone and lived normal lives, but they ended up having other issues that, in the process of getting to them to that point, they developed that were life-ending. And then you had a child whose mind you saved, but whose body you couldn't. And watching the family go through the grieving process of allowing their child to be made comfort measures, that's really hard when you've invested potentially months of effort trying to turn the tide, and ultimately failing to provide a long-term survivable outcome. So that's the worst part. And as I said, everyone deals with it different ways. I've found that most people who go into pediatric neurosurgery don't have children at the time that they make that decision. it seems like people who have children, when they consider pediatric neurosurgery as a field, tends to be a little harder to separate your home life from what you're seeing. And certainly that's not an absolute truth, but that's been my experience.
Well, switching over to talking a little bit about personal things, how do you balance work and your hobbies? It sounds like you work a lot and you really love your work. Do you have hobbies that you participate in and that you spend time on?
Yeah, I definitely am not just an infinite work machine. I have other interests. I do have hobbies. We'll get to this, but other interests, like for example, I'm in a hotel room right now because I have a lot of interest in technology and technology development. I've spent a lot of time working on new technologies to make neurosurgery better, and one part of that is finding a company that will make what you've developed. And so I spend a lot of time in kind of the startup era, or some of the startup arena. I don't personally have a lot of interest in running startups, but kind of working through the process of taking an idea, making a prototype, validating it, and then getting it made by somebody and ultimately picked up by a major manufacturer. That's kind of a side interest of mine that I spend a fair amount of time on. Hobbies are very important in neurosurgery, and outside interests. Neurosurgery is an infinitely overwhelming field. You could work forever and never be done. There's no end. There's very few neurosurgeons. That's intentional politically to kind of maintain a strong reimbursement model by our major political bodies. But the reality is for example, in my field or in my residency, there were 4 residents per year, and we'd have up to 18 to 20 ORs a day throughout the system, up to 100 to 150 patients on the list. And then you look at general surgery, and they would have the same patient numbers, but have 3, 4, 5, 6 times the residents. So it can be a lot of work. And so I've developed this perception that there's kind of a cutoff in terms of long term, not talking about residency, but in terms of long term, about the amount of time you can spend in the OR and still revert to a seemingly normal personality outside of the OR. I call it the 350 rule, which is just if you're doing more than 350 cases a year, you go a little crazy. The number is just an estimate. It's different for everyone, and obviously there are short cases and long cases, but that's kind of been my general profession or perception, that the surgeons that I've seen that go way over that number, they tend to be a little more rough around the edges, because you spend almost every moment of your life awake in a environment that you essentially have absolute control over. You are the master and commander of your OR, and that can be hard to turn off when you're spending 98% of your life in the OR. I found that the most important thing in residency was to anchor myself on repetitive and often simple activities to kind of keep myself sane. So during junior residency, that involved every week on my day off, I would go to a different restaurant. I would literally sometimes fall asleep at these restaurants, right? It didn't matter. What was important was the repetition, the separating myself from the hospital, doing a human activity with other people, interacting on a non-hospital level. That kept me sane. When I was older, I had a dog. I would walk that dog. Didn't matter what time I got home or when I went in. Every morning, every night, that dog got a long walk by the river. And yes, I had a dog walker. Don't worry, the dog was getting walked during the day too. But that was important. That was extremely important to my sense of well-being. In terms of now, I continue my interest in dance. My wife and I do a smattering of different jazz and Latin dances. There's a robust community in Pittsburgh for that. I also have a long-standing love of Chinese Shar-Pei. I have a Chinese Shar-Pei puppy named Sushi, who is about 1 year old now. She is a show dog, and we haven't decided if we're actually going to take her and do competitions, but she is of a champion bloodline. She's kind of been prepared for that. What people don't realize about dog shows is they're not sports; they're breeding conventions. So in order to participate, your dog has to be viable as a reproductive animal, and so they can't be spayed or neutered. So she's currently not spayed. But that really is kind of what we're debating in terms of competing versus having her spayed and her just being a family dog. And I have a lot of interest in kind of vintage menswear, and I'm a clothing enthusiast, we'll say.
Cool. It sounds like you've got a lot of stuff going on. So we have a few more questions here that have popped in. So this one is from Ambrose, who asks, how active is the pediatric neurosurgical research field?
So it's very active. There are a few. So to be clear, there's only about 300 pediatric neurosurgeons in the United States. So it's an super small field. So when I say a few, I'm talking about a dozen or two, but there are a few surgeons who are genuine scientists. I am not a scientist. I'm a surgeon who does science. It's a very big distinction. But I have two partners who are NIH R01 funded scientists, and they also do surgery, but they're real scientists. So yes, there is a lot of research activity on specifically brain tumors and functional epilepsy disorders in children. Clinically, there's lots of research going on. The problem is it's a very small field and it's a very rare field, so it's very hard to generate level 1 evidence on anything because it's very hard to do randomized controlled trials on surgical topics, especially when you're talking about things that maybe there's only a few hundred in the whole country per year. So there is a lot of quality improvement research that goes on, and but it tends to be multi-center institution based because it's very hard for any center, no matter how famous or how focused, to accrue enough patients on any specific topic to generate level 1 evidence. So it's a highly collaborative field. There's tons of registries and multi-center studies that have different focuses on hydrocephalus or spasticity. But as a basic science, true research field, there's only a few, probably dozen practitioners that I would say are actual scientists.
Okay, we have another question here. We're starting to run short on time, so we'll do this question, and then we have our wrap-up question. So this is another one from Weird Little Dreams, and they ask, what are your thoughts on the emergence of neurosurgery pre-residency programs?
So I'm gonna presume that when we're talking about pre-residency programs, we're talking about programs that you do after you graduate, but before you apply successfully into the match. Ultimately, any successful route into neurosurgery is a successful route. I worry that many of the pre-residency programs out there by the definition that I've outlaid do not have great outcomes in terms of the percentage of people that ultimately end up in neurosurgery. Now, if we're talking about programs like NYU, where you apply into medical school and you basically are guaranteed a neurosurgery program spot in that program when you finish medical school, that's great too. I think that that's totally a reasonable route into neurosurgery. But I worry that a lot of these pre-residency programs tend to have people in them that spend a lot of time in the field and then don't end up in neurosurgery. Now, they are often a necessity for non-US applicants, because it's very hard for someone coming from a different country to match into neurosurgery unless they've spent a number of years doing research and engaging in neurosurgery in this country. So for them, it is often the only viable option. But I would be hesitant to recommend someone devote multiple years of postgraduate time without reimbursement or with little reimbursement, without a strong prospect in terms of an eventual residency position. You're going to graduate minimum when you're like 34. So you really need to factor in, you don't get a coupon to relive your life after the end of this.
Yeah, it's definitely a lot of time to invest. So we're going to go ahead and wrap up with our final question here. And we thank to everybody who has submitted questions. This is one that we ask all the folks that we have do these Ask Me Anything webinars. And what advice do you have for students interested in pursuing medicine in general or neurosurgery specifically?
So my advice is to pursue interests and activities within or without a medicine that truly you're passionate about. I'm not a fan of resume padding, and there's a lot of pressure to do that kind of thing in highly competitive fields such as neurosurgery. I explored a lot of weird interests, including, as we talked about early, entomology. Those have had applications in my life since becoming a neurosurgeon. I think being a diverse person and having diverse interests and diverse perspectives ultimately results in unique insights and applications within a field. And I would much rather talk to somebody who was a competition weightlifter, about, well, what's your, like, what muscle is most important in weightlifting. I'd rather hear about them telling me about their calves and their diet of broccoli and chicken, that they spent time and they invested their passion in, than listening to someone tell me about the 1,000 hours they washed beds in the ER. Unique and interesting activities that you enjoy talking about ultimately are going to reflect more positively on you.
Great. Well, again, I want to thank Dr. McDowell for taking the time to participate in this Ask Me Anything webinar with us. We know your time is very valuable. We appreciate you taking the time to do this. And thanks to everybody who has been watching this webinar. We hope it has been useful for you. And we just like to, again, recommend that you check out the Student Doctor Network and some of the different tools that we have available there to help you as you pursue your journey to become a healthcare professional. So with that, we'll wrap up. So thank you again, Dr. McDowell, and good night, everybody.
Thank you.